So in last class, we discussed regarding some basic aspects of pediatric nutrition. In today's class, I will be discussing on uh, clinical features or various manifestations of nutritional disorder. And in third class, we'll be discussing on treatment aspect. Okay. So I'll go forward. Okay. So today's class objectives are we will be able to define what is nutritional status, how we assess nutritional status in children, and define certain terminologies like underweight, stunting, wasting, which will be uh, dis, uh, discussing on and off in pediatrics, and major micronutrient deficiencies, like some major ones like vitamin A, iodine, iron deficiency, and clinical features of mild, moderate, and severe undernutrition. So nutritional status is a state of body which results from the balance between intake and the expenditure of nutrients. So there should be a delicate balance between intake and the expense, like our bank balance. So unless we deposit regularly, if we expend more than our deposit, then we'll fall short. So in the same way, if there is intake is less and expense is high, so child will have undernutrition. And on the opposite, if intake is more and expense is less, then it will result into another form of malnutrition, that is overweight and obesity. In our part, especially developing countries or least developed countries, undernutrition, less intake is the manifestations are more common than the overweight or obesity. However, in developing countries like ours also, especially in affluent areas or more urbanized regions, you may get obesity or overweight increasing nowadays. So we are having mixed type of malnutrition. So both are abnormal, overweight or undernutrition. Now, how do we assess nutritional status of a child? So to remember, you can remember by this acronym ABCDE. Okay, so A stands for anthropometry, which we do in all children. So we measure various anthropometric measurements. I will come in detail, and more detail will be discussed in your clinical classes. Another is the biochemical testing. So we can test for certain levels of these nutrients, and whether they are normal or abnormal, we can test like that. Another is clinical examination for certain features. Another is dietary history. Again, this will be taken in all patients. And another way is the economic status. So socioeconomic status indirectly can tell you or reflect the nutritional status. Another is medical history. So if child has a chronic illness, be it pulmonary disease or renal or GI, it can also result into abnormality in nutritional status, because if child is falling sick frequently, they will require more expense or more calories or more nutrients, which regular intake may not be sufficient, and child will develop into undernutrition. So anthropometry, so in this you can see the various pictures, like we measure various body dimensions, especially weight. Is my cursor pointer visible?
Yes, sir.
Okay. So where is my cursor? Okay, there it is. So we measure weight by these weighing scales. So this is the infant weighing scale, and for length, this is infantometer, which is again you will be visiting our wards and you will observe this. You will be using regularly, and this is stadiometer for measuring height. So measuring tapes for measuring head circumference or mid upper arm circumference, and so this is the color coded tape measuring mid upper arm circumference. So you can see red, yellow, and green colored color coded tape. This is called as Sakir's measuring tape. And another is the skin fold thickness, which is measured at the triceps. The triceps or scapular region. And for these all measurements, you require age because weight, height, or length, this head circumference, these all vary according to age. So unless you know the age of the child, these values will not be helpful. And we compare these values, measured values, with the standard or expected values from the growth chart. Another is the clinical examination. So we examine for the features of nutritional deficiencies. So in general examination or general features like wasting, thin, very much thin, edema, skin changes, I will be discussing later. So there may be changes in mucous membrane in certain vitamin deficiencies or changes in activity levels or specific features of nutrients like macronutrients or underweight, stunting. I will be discussing in later part of this presentation. Another way of nutritional assessment is by dietary assessment. So commonly we calculate dietary intake by 24-hour food recall method. So in this technique, we ask patient how much food or which food items did the child took in last 24 hours. So name of the food, amount, and from that we calculate what is the calorie values of these food items or protein levels of these food items, and we add it and we can come towards how much calories or how much proteins they have taken in 24 hours and whether this is sufficient for that age or not. So in first class we discussed about nutritional requirement according to age, and also the calories or proteins values of different food items. So you need to remember these. And we compare with the recommended daily allowance whether they are it is normal or low, and we can plan accordingly. Economic or education status also can reflect the nutritional status. So again, this is beyond our control. So poverty, availability, or access or utilization of food can result into undernutrition. You can see because of this, our remote part may have more undernourished child as compared to urban area. Okay, and education level also determines or at some level, because they know after education they know how to give proper nutrients. Okay, so this is a photograph of not from Nepal, fortunately. So this photo received Pulitzer Prize in 1994, and this was photo of in 1994 in a Sudan famine. So this, you can see a thin-built child with ribs visible, the hands and legs, they are very much thin. So the child was crawling or towards the UN relief camp for food. And you can see behind the child, there is a vulture, which is again following the child. The child dies, and so that vulture can eat the. So this is a very horrific photograph. Okay, so after assessing the nutritional status, nutritional intake, okay, so how do we classify the nutritional status of a child? So there are various parameters, various classification systems are there, but commonly we use it can be classified according to the age, weight for age, length or height for the age. So another parameter which you should not forget is the weight for length or height. So the first one is, it depends on age. Now the weight for length or weight for height means it depends on the certain length. So this is okay. Another is based on Z scores, presence or absence of edema, or there are certain age independent indices. So in certain scenarios, we may not be able to ascertain the exact age of child. So in that case, the above parameters will not help you. Okay, if you do not know whether child is 3 years old or 7 years old, we cannot say whether weight or length is normal or abnormal for that child. Now, certain terminologies we should be familiar with, like underweight. So this means a child whose weight is less than 80% of expected weight for that age, or Z score less than -2. Sorry, there is no less than. Okay, this is typo error. So there should be less than -2. So that expected weight or Z score can be calculated from the growth chart. I think I will not be able to discuss right now. These will be discussed in detail in your clinical postings. Okay. And if you turn your textbooks, you will find there are growth charts with percentile as well as the Z scores. Stunting means the height or length is less than 90%. Please remember these centiles, okay, percentages. So for weight, it's 80%, less than 80%. For length or height, it's less than 90%. But for Z score, it's less than -2. Wasted means weight for height. The parameter is different. So weight for height or length, which is again less than 80% of expected, or Z score less than -2. And if child's height or length is less than 90% and weight for height is less than 80%, so this child has both stunting as well as wasting. So is it clear?
Yes, sir.
Okay. Now there are various classification systems out there depending on the parameter. The very old one or very famous one, unfortunately we do not use this classification right now, but very simple one. So this is called Gomes classification, which takes weight for age as a parameter. So more than 90%, though I have said in earlier slide, it's more than 80%. So this is old classification. It takes more than 90% of expected is as norm. So grade 1, grade 2, grade 3, depending on the percentage of expected. I just know the name. Now, this classification, you should be remembering all. Nowadays, we use this WHO classification for categorization of malnutrition. So it has classified into two: moderate undernutrition and severe undernutrition. And three parameters are taken: presence of edema, weight for height, please remember it. This is not weight for age, weight for height, and height for age. So Z score or ST score, -2 to -3, moderate. Okay. If it is less than -3, it is called as severe one. And so in severe one, there will be edema. Z score will be less than -3 for both weight for height as well as height for age. And recently they have introduced one new parameter, that is mid upper arm circumference. Okay. Now, this is Iep classification, Indian Academy of Pediatric classification. Again, this takes account of weight for age. So normal is more than 80%, and depending on percentage, it is classified grade 1, 2, 3, and 4. And K, suffix K is added. So grade 1 K means 71 to 80% of expected weight with edema. So suffix K is added if edema is present. Another is welcome trust classification. So this takes two parameters, weight for age and presence or absence of edema. So underweight, if weight is 60 to 80%, but there is no edema. Kwashiorkor, weight is 60 to 80%, but presence of edema. Marasmus means weight is significantly low, so less than 60%, but there is no edema. And both present, then it is called as marasmic kwashiorkor. So this is again old classification. Nowadays we do not use, but to understand the severe forms of malnutrition, this classification is helpful. Okay. Especially older generation, they are continuing to use these terminologies like kwashiorkor, marasmus. Nowadays we usually say severe malnutrition or severe undernutrition. Another classification is Waterloo classification. So this takes weight for height, and length for age. So weight for height, more than 80% of expected is considered normal, and length, more than 90% of expected is considered as normal. So depending on these parameters, wasted, stunted, or wasted and stunted both. This classification helps you to tell about the physiology or process of malnutrition. So if height is normal, like in this case, height is normal, but weight for height is low. So this means there is acute malnutrition. So whatever disease that occurring, the malnutrition process, it has occurred for the very short period. Whereas if a child is stunted, so height is low and weight is normal, it means, or it indicates, where is my cursor? Okay, so it indicates chronic malnutrition. So this process has going on for a long time. But if both are reduced, height is also low, weight for height is also low, it means the child has chronic malnutrition. On top of that, there is some acute process which resulted into increased level of malnutrition. Okay, so this classification helps you to tell about the malnutrition process. So why this malnutrition is important? So a recent survey from WHO has estimated that almost 45% of child deaths below 5 years of age, they are related to undernutrition. The primary cause may be diarrhea or measles or pneumonia, but the common denominator, all of more, so 45 children will have some form of undernutrition. So this is a very significant comorbidity leading to death. This is again old slide which I used in your floss class. So you can see still almost 36% of children below 5 years of age in Nepal are stunted. 27% they are underweight. So still 1/3 of children, they are malnourished in our country. And previously we used to the more problem of undernutrition. There is stunting or wasting. But now there is third phase of malnutrition coming up. Like many children, they are also becoming overweight, which is also not a good. Okay. Now, what are the features of undernutrition? So mild malnutrition, it results into growth failure. There will be, if you plot their growth, there will be slowing of their increase in weight or increase in height, or it will be static. They will have infections. So there may be presence of diarrhea or respiratory tract infections, or there may be features of micronutrient deficiencies. Okay. Whereas moderate malnutrition, they will have these parameters. So there will be wasting, weight for height will be less than, Z score will be less than between -2 to -3. Height for age will be, Z score will be -2 to -3. And there may be associated micronutrient deficiencies. So weight, height are both low in moderate malnutrition. Now in severe malnutrition, so there will be severe wasting, there will be severe stunting, there will be presence of bipedal edema, or there may be mid upper arm circumference less than 11.5. And there is a term called severe acute malnutrition. Acronym is SAM, S-A-M. So this takes parameter of severe wasting, edema, and mid upper arm circumference. So this excludes the chronic one, in which the height is low. This is taken separately because the mortality of severe acute malnutrition is very high. Okay. Now I will be discussing of severe features of severe malnutrition, and there are two extremes of severe malnutrition. On one extreme, there is kwashiorkor, where the child is edematous. Weight is low, but not so significantly low. And in another extreme, there is marasmus. So weight is significantly low, but there is no edema. And unfortunately, most of children will have both mixed features. Okay. So in kwashiorkor, what happens is, you can see in this photograph, child is looking distant, not interested in surrounding, like irritable. Okay. So there will be hair changes, there will be hypopigmentation of hair, there will be moon faces because of edema, muscles will be thin. You can see the legs are swollen. There may be skin changes. This is black and white photo, so I could not, you may not be able to appreciate clearly. So these are few photographs of kwashiorkor. So you can see in both picture, both child are irritable. There is edema. As you can see, protruded abdomen, skin, the ears are sparse, and there may be alternate normal color and hypopigmentation. So this is called as flag sign. So when the nutrition is good, food intake is good, there will be normal hair, and during period of deprivation, nutritional deprivation, there will be hypopigmentation. So alternate bands of hypopigmented and normal colored skin is hair. So in this child, you can see moon faces. You can see ulcerations over the angles of mouth. So ears are sparse. Okay. And these are few skin changes seen in kwashiorkor. So skin is peeling like a old paint. You may be finding in old buildings, the old enamel paints are, these flakes are coming. So like this is called as flaky paint dermatosis. And you can see the pigmentation like a marble. So crazy pigment dermatosis. So you can see in this child as edema as well as the skin changes. So now another extreme, there is marasmus, where the child is very thin built. You can see in these photographs. So hand, upper limb and lower limb, so much skin, thin, just bones are visible. There are loose skin folds and monkey looking faces or old man look face. And in this form of severe malnutrition, there will not be edema and child is not irritable. Okay, so in this photograph, you can see the child looks very much emaciated. Reefs are so much visible. Skin folds are loosened and appearing old man. So this table differentiates features between quasi-worker and marasmus. So growth failure will occur in both, wasting more marked in the marasmus. Edema will be present in quasi-worker. Air changes are more in quasi-worker. Mental changes, so child will be apathetic, irritable, which is more common in quasi-worker. Dermatosis, skin changes will be common in quasi-worker. And one striking feature between these two to differentiate, in marasmus, appetite is good. It is preserved. If you give food to a marasmic child, a child will eat voraciously. Whereas in quasi-worker, child, the intake is very poor. Okay, so these are, and hepatomegaly may be present in quasi-worker because of fatty infiltration. So these are few contrasting features between quasi-worker and marasmus, but in clinical practice, more commonly we see mixed feature. So some of features of quasi-worker and some of features of marasmus in a same child. Okay, so far any questions? Any questions so far? Okay, if not, I will proceed.
No, sir.
Okay. If I'm going a little bit fast, please stop in between. Okay. So after dealing, so these are all these quasi. What we are talking is these are more related to deficiency of calories and proteins, which are the macronutrients. Now I will be discussing towards the micronutrient deficiencies or vitamin deficiencies. Now, vitamin A deficiency leads to xerophthalmia, and this vitamin A is a major factor for growth as well as it is related to vision. So there will be very but in daytime it's normal. Okay, नेपालीमा रतन्दो भन्छ नि हैन. Now
Recording stopped.
sorry,
Recording
I
in
think,
progress.
okay. Okay, is it visible? Sorry, it got disconnected.
Yes, sir.
So in the first photograph, so you can see the white, chalky white, dry looking thing, plaque like thing. So this is called as bitered spots. It remains dry even if there is it is not wet by the tears. Okay, so this white part is called as bitered spot. And if this is in severe cases, you may get keratomalacia, dryness of whole cornea. There may be ulceration, and ultimately it can lead to scarring. And if scar is in the central part of cornea, it can lead to blindness. Just see the severity of disease. So vitamin deficiency leading to a permanent blindness, which is very unfortunate. So we need to prevent a child from vitamin A deficiency. And if they are deficient, we need to identify early and then treat. so that the child don't go into a blind status. So WHO has classified depending on the severity. So primary signs, so X1A, X1B, X2, X3A, X3B, and secondary signs as XN, XF, and XS. So first stage will be conjunctival xerosis, then whited spot. If severe, corneal xerosis, and more severe, corneal ulceration involving less than one third. More severe will be corneal ulceration more than one third. And secondary signs means the disease has already evolved and led to some permanent changes like corneal scarring or fundal changes. Unfortunately, because of vitamin A prophylaxis, you may be hearing in your radio or newspapers. So in our country, all children below 5 years of age, they are given vitamin A twice a year in Baisakh and Kartik. And after launching this program, we have reduced the incidence of xerophthalmia in our part of country, okay? Which is a good government initiative. Now, another micronutrient deficiency, which is again prevalent, especially in the hilly region of our country, is the iodine deficiency, which leads to, if the iodine deficiency is in utero, so during fetal life, it can cause abortion or stillbirth or congenital anomalies. And if child is born, it can lead to cretinism, which is a mental retardation. There will be developmental delay. तिमीले देख्छौ नि लाटो सुस्त मनस्थितिको कान नसुन्ने लठेब्रो भन्छ नि, maybe these are born because of intrauterine iodine deficiency. So if this can be detected in newborn itself, so infants, they will have large tongue. You can see in this photograph the protruded tongue. The skin will be dry. They will have prolonged neonatal jaundice. They will have constipation. They will have large umbilical hernia. And if you monitor their development, it will be developmental delay. They will not be able to perform the various tasks timely. Because iodine is required for the neuronal or brain maturation as well as physical growth. I think I will not be discussing specific function of these micronutrients, because if I go in depth, I will not be able to finish my class. And I think these were discussed in your physiology or biochemistry classes, isn't it? So you need to refresh those knowledge. If iodine deficiency occurs beyond the infancy, where almost brain maturation has occurred, growth has occurred, so it will lead to goiter. So you can see in this photograph, in the neck region, there is a large swelling. It will cause impaired mental function. There will be physical and sexual retardation. Growth retardation will occur. And again, the problem of iodine deficiency has reduced because of increased awareness, the implementation of compulsory iodized salt. So these interventions have reduced the occurrence of iodine deficiency in our part. Another major micronutrient is
Recording stopped. Recording in progress.
So where are we? So we're discussing of iodine deficiency anemia. Okay, so child will look pale. So there will be conjunctival pallor, hands and palms will be pale. And if you see the blood film, there will be hemoglobin will be low and microcytic hypochromic anemia will be present. Okay. Okay. Other deficiencies will be vitamin B deficiencies. So there are so many vitamin B complexes. So first one is the thiamine deficiency leads to beriberi. So there will be angular cheilitis, okay, angular ulcerations over the mouth. There will be even neurological form. There will be edema, may result into cardiac failure. So there are other signs. Folic acid deficiency will lead to megaloblastic anemia, and if it is deficient during in utero, it can result into neural tube defects, meningomyelocele, spina bifida. Okay, so niacin deficiency will lead to pellagra. So 3Ds: dermatitis, necklace diarrhea. So dermatitis over the necklace region. Where is my cursor? Okay, so necklace region. And so this dermatitis is occurring especially the exposed part, sort of photosensitive, and glossitis, diarrhea. Okay, B12 deficiencies lead to glossitis and megaloblastic anemia, and sometimes neurological manifestation can occur. Vitamin C, another vitamin which leads to deficiency state, is called as scurvy. So you'll have bony changes. So this is vitamin C is related to our immunity as well as the cartilages. So it can cause gum bleeding uh, because of blood vessel abnormalities, weakness in the blood vessel, or it can cause prominent costochondral junction. Seen in this photograph, you can see the costochondral junctions are very prominent. You can see these prominences. So these are called as scorbutic rosary and gum bleeding or petechial spots. Another vitamin which is important is the rickets. So these are related to bony growth. So it will lead to short stature, delay in closure of anterior fontanelle. Again, it can lead to bowing of legs, deformity, bony deformity. So you can see knees are quite adjacent. This is called a knock knee. You can see this is a curved lower limb. This is bowing of leg. This is called rachitic rosary. You can see the wrists are swollen and deformed. And if you do X-ray, there will be a classical picture of rickety changes. Now, another micronutrient which is relevant one is the zinc. Again, very important for the growth, physical as well as gonadal growth. So it leads to acrodermatitis. So dermatitis involving the perioral region and the genitalia part. Okay, so you can see the perioral as well as the genitalia. So acrodermatitis, as well as it can, if it is prolonged, then it can lead to hypogonadism also, short stature. I will sum up this micronutrient deficiency. So nutrient and their deficiency states. Just this is sum up. I've told all one. Okay. So vitamin A leads to xerophthalmia, thiamine deficiency, that is B1, beriberi, riboflavin, riboflavinosis, niacin deficiency leads to pellagra, pyridoxine deficiency lead to peripheral neuritis, vitamin C deficiency leads to scurvy, and calciferol or vitamin D deficiency leads to rickets. So folic acid deficiency will lead to anemia, neural tube defects, vitamin B12 deficiency, so pernicious anemia, and vitamin E, which is related to, again, immunity. So it will cause enhanced aging. There are certain minerals which are relevant for our growth or maintenance of health. So calcium, there is no effect if there is vitamin D is normal. It will normalize the vitamin calcium level. Fluorine, it can lead to dental caries. For phosphorus, exactly not known, but it is a cofactor. It is related to other bony growth. Sodium, potassium, magnesium, iron. So these are various minerals. Okay. So far, any questions? So regarding the clinical features of micronutrients or vitamins, I have not discussed. I have discussed more of clinical features. I have not gone into depth of their actions, what they are, why they are important in our health, their requirements. So these you need to refresh from your textbook. So some of things you already know it, especially the function part. What is the role in our health? Now the requirement part, I think you need to study your book and take from that. Okay, any questions?
No, sir.
So I would like to show this. This is old photograph. What do you observe in this photograph? Anyone can tell me? Anybody? This is not taken by me. You can see Key West. I think this person is some foreigner who worked for nutrition related programs in Nepal in late 90s or early 90s. I don't know.
So त्यो बच्चा malnourished देखिरहेको छ.
Okay. So बच्चा सानो देखिरहेछ. हेयर्स अलिकति कस्तो फोटो अलिक क्लियर छैन तर स्टिल ओके अलिकति ओल्ड म्यान लुक जस्तो अलि मंकी टाइपको देखिरहेछ हैन. ओके अरु के अब्जर्भ गर्यो?
त्यो आर्मको सर्कमफरेन्स पनि एकदम सानो छ.
ओके हुन सक्छ. So
अनि बोटल फिट गर्दै
बोटल के ओके बोटल फिट ओके. सो बोटल के को बोटल छ?
रक्सीको बोतल.
So you can see what will be the hygiene of that. So हाम्रो concept still हाम्रोमा के छ concept भन्दाखेरि we have food, nutritional food, but we don't know how to utilize. Okay, हाम्रो concept के छ भने still packet को चीज पैसा तिरेर किनेको चीज चाहिँ राम्रो हुन्छ. So rather than mother's milk, the concept is हैन प्याकेटमा किनेको मिल्क चाहिँ महँगो गरी किनेको चाहिँ राम्रो होला बच्चाको लागि भन्ने त्यो कन्सेप्ट छ हैन. सो एफोर्डेबिलिटी इस्यु होला. त बोतल किन्न सकिरहेको छैन तर दुध चाहिँ बट्टाको दुध खुवाइरहेको होला हैन. बट बोतल पनि कस्तो अब हाइजिन कस्तो होला हेर त्यहाँ. एन्ड दिस फल्टी न्युट्रिसनल प्र्याक्टिस इग्नोरेन्स हैन भएर पनि कति ठाउँमा त नभएर हो. खानेकुरै छैन, पोभर्टी छ, किन्ने पैसा छैन. तर कति ठाउँमा किन्ने पैसा छ, थाहा छ, खानेकुरा पनि छ, तर हाउ टु कसरी खुवाउने थाहा नभएर many children, they are falling malnourished. Okay. So I think I have concluded my class today. So if there are no questions, we can end our session.
Okay, sir.
So all of us need to move up. हैन तिमीहरुको पनि कति क्लास जानु पर्छ हैन अब